example, we put the title "Working Together Makes the Difference." Illustrative cases from the Cancer Center Zürich. So it will be Niklaus Andratschke and Britschgi who share this talk.
Thank you for the introduction.
Thank you very much, Rolf. Yes, we would like to present an illustrative case. We think it's illustrative, and I would like to start with the outline, which might look familiar to you. Professor Guggenberger already presented the concept of oligometastatic disease, and in this situation we have a patient who presents with locally advanced lung cancer within the chest, but also with a singular brain metastasis sitting in the vermis cerebelli. These are the patient outline. So he first presented with a post-stenotic pneumonia. There was the staging work done, and this solitary metastasis in the vermis has been detected and was considered to be critical, and therefore the patient was taken to the neurosurgery department. This lesion has then been removed, so for two reasons: critical location, getting histology, but taken together, the first clinical stage was a CT3 tumor, advanced nodal disease, and this singular brain metastasis. So the first treatment consisted of surgery to get the histology, and afterwards, because this is the standard of care at the Department of Radiation Oncology here in Zurich, stereotactic radiosurgery to the resection cavity. We're discussing today cases, or we're discussing guidelines and beyond. We still need to be aware that there has been a randomized trial. It's not fully published, but up to now, although this has been practiced in our department for right now 3 years, there's no formal level 1 evidence comparing post-operative resection cavity stereotactic treatment to, for example, whole brain radiotherapy or only surgery. So again, with this patient, we already moved beyond the guidelines in this treatment setting. And we need to be aware, although we are talking about oligometastatic disease, with brain metastasis, we have this nice tool with the graded prognostic assessment, which we can calculate disease specific for this patient. And if we calculate this, the patient receives a quite reasonable, quite good GPA score, and the expected overall survival is projected to be around 9 months. So we have already discussed this. We have already discussed this study from Dirk de Roosje, and we need to be aware that almost half of these patients presented with brain metastasis and were then included into this trial. And there the patient had median overall survival of 13.5 months. And with the local treatment, very few local recurrences have been observed. And going beyond that, this is just another example of an oligometastatic trial in non-small cell lung cancer, where we have radical treatment of the primary tumor and then radical treatment of up to 3 local metastases in the primary setting. So with this patient, we are within the scope of oligometastatic disease, and we could discuss treating this patient this way.
Exactly. After that, we now have to talk about the local situation, so treating the thoracic disease. And as we've introduced, it was locally advanced lung cancer, and as you are all aware of, there we need to have a close look at the histopathology and also at the immunohistochemistry to decide how to best treat the patient. Because one cornerstone... Is it switched off? Oh, I'm sorry. Not supposed to be on. Is it better now?
Otherwise you take this one and
then the problems should be solved, right? We have to have a close look at histology in order to choose the best systemic therapy. Now, as already on the first slide we introduced, the patient had a large cell neuroendocrine carcinoma, was TTF1 negative, and those 2 neuroendocrine markers stained positive. And we also assessed the oncogenic driver mutations, which at that time would have had a consequence in first-line treatment. Nowadays, as Professor Stahel has pointed out, we would also test for ROS1, but at that time those 2 markers were tested. EGFR was negative, so wild type, no activating mutation, And the ALK FISH to detect the translocation was not conclusive. There were too many necroses in the tumor, but ALK immunohistochemistry was only weakly, so for all practical purposes, we could assume that the patient was negative also for the ALK translocation. So the decision was that he should be treated with a combination chemotherapy, a platinum doublet, and we also added a mediastinal definitive radiotherapy to this treatment to have the most aggressive local treatment. And this is the timeline. So the patient was diagnosed in 11/2014. He was operated, had a postoperative radiotherapy, and then we started the local therapy. And he had a very good response, as illustrated here by the PET scan in March 2015. But then, a little later, or actually while he was still being under local treatment, he developed new brain mets. And that's when I have to hand over to my colleague from radiation oncology.
So right now it looks like, as it was a pretty clear and easy decision for us in this oligometastatic setting to go for aggressive chemoradiotherapy. To be honest, it wasn't this way. At that time, it was not a clear, for us, standard or procedure. Actually, the patient started with chemotherapy and was then brought back to the tumor board, where we then together decided this would be a reasonable case to follow the strategy of the Arusha. But only shortly later, he developed 4 very small and tiny lesions while he was on the systemic treatment. And if we then still calculate the GPA score, which we need to calculate at this time point where the new metastases have been detected, we still came up with a GPA score of 3, and right now, and this was a very early case where we decided not to go for whole brain radiotherapy, but for focused local radiosurgery and repeat radiosurgery. So actually this is a very new concept, and to be honest, this publication just recently was published from the Stanford group, around 100 patients repeatedly treating in total over 600 metastases, showing a very good local control even in the repeat setting, what we basically would expect. And of course, we see progression during the course of the patient's disease, but all these progressing lesions have been retreated accordingly, and in the total group, the overall survival, if we would look at the patient prognostic scores, is quite reasonable. So basically the idea is not to go too early to whole brain radiotherapy, but to defer it until polygoprogression within the brain. And we collected our own experience that basically started very early after we started the radiosurgery service here. We have now approximately 35 patients, but we evaluated 23 with up to 114 metastases. Local control is very good. It's around 85%. We have a comparable out-of-field recurrence rate, meaning we treat the patient locally, and after 3 to 6 months, 2 to 4 metastases are reappearing. But if we look at the survival of these patients, we have a median survival of these patients we have now analyzed of 22 months. So it's a very reasonable survival in this patient cohort with recurrent brain disease. So I think at least the strategy with respect to deferring the whole brain radiotherapy and with respect to overall survival is very reasonable. Unfortunately, only 3 months later, and this is depicted here, the patient developed polygoprogression. So we're not talking about 3 or 4 or 6 metastases. He developed more than 10 metastases and then finally received whole brain radiotherapy. And if we now calculate the GPA, just because of the multiple brain metastases, it only drops to 2.5 and doesn't really change the projected overall survival we would see.
Now let's come back to the systemic situation again. At the time the brain metastases were diagnosed, the patient was still good controlled locally, as you can see here. This was most likely due to a local infection. But then only 3 months later, he had systemic progression. You can see here a new metastasis in the liver, adrenal gland, and also locally in the mediastinum. So we had to choose second-line therapy. And as we have learned from the previous 2 talks, in second line, we have to have a look again at the oncogenic driver mutations. Remember, the patient was negative for EGFR and ALK, and then we proceeded with next-generation sequencing to search for other druggable aberrations. Those were the aberrations found. He had a mutation in the PI3 kinase pathway, which was activating, as illustrated here, with the downstream target, which is phosphorylated. And this has already been described also in large cell neuroendocrine carcinoma of the lung. So that's an aberration which is quite frequently present. However, it doesn't have any therapeutical implications as of now. There is no drug which would be established in second line. And so I don't have to go into details into this data. After the previous talk of Professor Peters, the obvious choice was to start the patient on an immune checkpoint inhibition, and we started treatment with nivolumab in August 2015, and he responded very well. But then, again, I have to hand over in December 2015. I had to call Niklaus Andratschke again.
While he was on immunotherapy, he developed further oligoprogression in the brain. It was very interesting to see in this patient that with his numerous metastases, the only 10x3 schedule quite nicely controlled the small lesions, but he had new recurrent lesions. Because we already had given whole brain irradiation, we decided to go again for stereotactic radiotherapy, this time in a fractionated way, to be a little bit more careful, because we also had one lesion within a pre-irradiated area and nearby the brainstem. He received 6x5 gray. And now, if we look at this calculated GPA, not because of his brain metastasis, but because the patient had a simultaneous extracranial metastasis, or had developed simultaneous extracranial metastasis, the GPA now drops, and the expected overall survival in this patient would have been 5.5 months. So what we did in addition, this was only a bone metastasis, where we did, because we still considered the patient extracranially as an oligometastatic case, we did a high-dose stereotactic treatment, treating prophylactically the whole vertebral body, but selectively the PET-positive area with a significantly higher dose to an equivalent dose of 60 gray in 2 gray single fraction. But while the patient was still on immunotherapy, he developed recurrence in the liver, and also here recurrence in an adrenal gland. Where we then decided, because it were only 2 lesions extracranially, to give him another set of stereotactic treatment. You see here quite high doses in the liver, and this was inhomogeneously dosed, so this was again a dosage of around 60 gray equivalent in 2 gray fraction. Here's the projected GPA again, still everything oligoprogressive, and if we would calculate it based on the brain metastasis, we would project the overall survival of 5.5 months.
Then in August 2016, the patient presented on the emergency ward due to a seizure, and on brain imaging it was diagnosed that he had again progressive CNS metastases. Importantly, at that time, he still had a near complete remission systemically. So the radiotherapy had obviously worked, and nivolumab actually went on to work systemically, but the CNS was not controlled anymore. And unfortunately, a radiotherapy was not possible anymore. At that time, maybe you can comment on that.
So the reason was that, especially in the posterior fossa, we had already given whole brain irradiation and 2 courses of radiosurgery to, in total, 5 metastases, and this would have been a 3rd radiotherapy in this area. So we decided not to go for another course of radiotherapy, but to salvage the patient systemically.
Exactly. So we had to decide again on a systemic treatment. And after discussion within the lung group and the tumor board, we actually decided to re-challenge the patient with carboplatinum and etoposide, given the fact that he had responded well initially to that. And indeed, he responded. So there was a response in the CNS. The patient completed 6 cycles of this chemotherapy right before Christmas. And we have seen him recently. He's doing fine. He's controlled. And now the $1 million question is obviously how to go on.
How to go on with the patient.
The question also for the experts in the audience, right? Yeah. So chemotherapy is completed, and currently he's on a therapy break.
Yeah, and to be honest, it's a very important question how to go on, but also looking back, did we take the right decisions? It's always much easier to take the retrospective scope, but I think this case is quite illustrative. It started in November 2014, and now we are in January 2017. The patient is feeling quite well with a performance status of 0 currently, and if we project this new situation with the recurrent brain metastases that are now symptomatic, we are coming to a GPA of 1.5 mid of last year. But if we now summarize the whole situation, the diagnosis in November 2014, where we projected the survival of 9 months, and basically till then it's 25 months, and we can go down this list even until his 5th progression. We salvaged while he was still on immunotherapy with local treatment, and afterwards again with the systemic re-challenge, we have hit all median overall survival, and we even have hit all upper confidence interval limits. And right now, I'm quite confident we will hit the last limit as well, but at some point, I think it will not work on like that. Thank you very much.
Thank you very much. So maybe I can have a question to the floor.
Yes,
the first question would be, who would have started nivolumab right?
Well, I don't know that so long as there is data of immune checkpoint inhibitor having an anti-tumor activity in CNS metastases, so it's quite, but of course it may not be as efficacious. But I think what I like in this case, and this is how we try to practice in our team, we don't give up so easy. We always try to go with the patient, of course, in discussion with the patient, so he's informed a step further. Mm-hmm. I think let's wait what happens before we go to recommendations. Okay, thanks very much. So we'll come to